thank you for having me again. Try to advance the slides, but it doesn't seem to. There it goes. Now, talking about pharmacotherapy for MASLD brings us, of course, back first of all to the pathophysiology that I showed you before, and we also saw it in other presentations. But we should take into account that the pathophysiology is very complex. So you have all the different mechanisms that happen inside the liver, and you have all the different organs with which the liver is in a complex crosstalk. And again, the disease pathophysiology is not just a matter of what happens inside the liver. First of all, what happens inside the liver is anyhow a balance between damage and repair. And the damage does not come from the fibrogenesis directly, but of course there are upstream mechanisms, and much of the metabolic and inflammatory drivers of the disease are coming from outside the liver. And as I said, there are obviously also mechanisms inside the liver. So we have many different targets that we can envision, but there's also a risk if we tackle just one target that it's too narrow in such a complex ecosystem. Now, Professor Khalid also referred already a little bit to the framework that defines the pharmacotherapy or the development of pharmacotherapy for this disease. And we know, of course, that fibrosis is the most important predictor of prognosis. But we should be realistic. It's not just about fibrosis. Cirrhosis is not just about fibrosis. You have also the vascular mechanisms. And so, although fibrosis as a readout of a long-standing active progressive disease is an important predictor of prognosis, what drives the disease is the underlying damage and inflammation. It's the steatohepatitis that drives the disease and is also the most important target then for the pharmacological therapy, and not the end product of fibrosis as such for most of the approaches. Now, in terms of the framework to get really drugs on the market with steatohepatitis as an indication, currently, just because of what I just said, the target population for that is not every patient with MASLD. MASLD is anyhow a sign of being metabolically unhealthy, so there must be something done about it. But starting a drug specifically for the liver in this condition requires the presence of an underlying active inflammation and damage. So there needs to be steatohepatitis, active disease with some degree of fibrosis, because that means that the patients are at risk of progressive disease until cirrhosis and the complications thereof. That's why the target population for pharmacological treatment that is specifically started to treat MASH, not to start the treatment of obesity or diabetes, but specifically to treat MASH, is in that target population. And also the regulatory framework, and that's also something Professor Khalid already explained, is because the disease course is long, is based on a process of accelerated or conditional approval on interim surrogate endpoints, and for the time being, those surrogate endpoints in phase 3 trials, at least in the non-cirrhotic population, are based on liver histology. There might be a different position in the future, but not in the near future, even if regulatory bodies like the FDA are open to consider NITs in the future. It's still currently, and probably for the next period, still based on liver histology for having MASH, again, as an indication in the label of the drug. And of course, in the end, we need clinical outcomes for a definite non-conditional approval. It's also important to realize that even those histological endpoints that we define, resolution of NASH or MASH and or the regression of fibrosis, they are reasonably likely surrogates. They have not been validated as surrogates for improved clinical outcomes. This is important, specifically when it comes then to the establishment of the guidelines, because, for example, with pioglitazone, already a long time ago, mid-2006, there was a first positive trial on the effect of pioglitazone, so mainly PPAR gamma component, on steatohepatitis and steatosis with some subsequent studies that have confirmed that. You see, compared to placebo, up to 30% resolution of MASH in the high-dose pioglitazone, and also some improvement of fibrosis, although it did not hit the endpoint of one stage regression of fibrosis. Now, this was not, or this has never been a proper phase 3 trial, so that's why pioglitazone will not have MASH in its label, and why also in guidelines like we have established with EASL, ASO, and ASD, as I mentioned in my previous talk, we did not recommend or withheld pioglitazone as a drug to start specifically to treat MASH. Of course, in the context of a patient having diabetes and also MASH, it's useful to start pioglitazone, and it can have for sure a benefit also on the liver, but we cannot say currently that we can recommend it as a specific anti-MASH drug, so that's why it's formulated that way in the guidelines. Coming back to resmetirom, which was also shown at several occasions, this is a liver-targeted drug. That's very important to take into account. So there is some intrahepatic hypothyroidism in MASH, as we know, and with agonism of the TRH-beta, we can improve energy expenditure, mitochondrial function, and lipid handling in the liver, which has an impact on steatosis and steatohepatitis, and also, as was clearly shown in a phase 3 trial, on fibrosis. So this drug hit both the endpoint of MASH resolution and fibrosis regression, and therefore it has been approved by the FDA and later on also by the EMA. Now, what is important, if you look at the label that has been issued by the FDA, and later on it has been copy-pasted more or less by other agencies, the indication is, again, non-cirrhotic. Why non-cirrhotic? Because we don't have the data so far in patients with cirrhosis. So non-cirrhotic, non-alcoholic steatohepatitis. So FDA still use the old nomenclature, but the important point here is the indication is steatohepatitis. We're not treating steatosis, we're not treating just fibrosis, we're treating patients with steatohepatitis and fibrosis. That's the target population for this drug. And the FDA did not tell us how we had to make that diagnosis. It just tells you what the indication is. And if one day we can make that indication without a liver biopsy, we do not need a liver biopsy. The question is only, can we make the indication or the appropriate diagnosis for the time being with the liver biopsy? That's, of course, the main question. And as I said, EMA has adopted more or less the same wording. We anticipated that in the clinical practice guideline by saying that if approved locally and depending on the label, adults with non-cirrhotic MASH and significant liver fibrosis should be considered for treatment with resmetirom, so that's already in the guidelines. And as Professor Khalid said, ASLD colleagues have issued a more practical guidance on how this can be then started in clinical practice without the need for a liver biopsy. And as he showed, it's mainly, of course, again, to exclude patients with cirrhosis if the liver stiffness is too high, and one of the most important measurements is, of course, the fibroscan or MRE. You can also base it on ELF. So if it's too high, then the risk of cirrhosis is there, so we will not use resmetirom. But mainly if you have a liver stiffness, if we take that as the most accessible parameter between 10 and 20, then it's a potential indication for resmetirom. Now this is, in terms as far as liver stiffness is a marker of fibrosis, a very fibrosis-oriented approach. And this approach has been criticized by several studies. This is one on a large biopsy-based study showing you that in the category of those with VCTE between 10 and 20, which is, as I said, the target that was coming from the guidance of our ASLD colleagues, about 60% in the end did not qualify for resmetirom treatment because there was not enough fibrosis, or whether the fibrosis was too advanced, but mainly because there was no true steatohepatitis. And also below and above those thresholds, there is a substantial number of patients that are misqualified. So we should for sure improve on that and find ways to better select patients and not just focus on fibrosis, but also the presence of steatohepatitis. For resmetirom. Then the GLP-1s, once again, and it's important to emphasize that we have very little arguments that there is a direct effect of GLP-1s in the liver, so there are a lot of beneficial effects that can drive also liver improvement, but it's mainly, coming back to my scheme, extrahepatic metabolic milieu that drastically improves. What was included in our guideline is that in the absence, and you should be mindful that that was from 2024, and that in the absence of formal demonstration of histological benefit, remember the phase 2 trial was not positive on fibrosis regression, we in the guideline said that we could not recommend at that time the GLP-1s and most notably semaglutide as a MASH targeted treatment, just because we did not have those data on the phase 3 trial. Now, this shows you also how rapidly those guidelines can be outdated, because quite shortly after the publication of the guideline, we had the phase 3 data of semaglutide clearly showing a benefit on both MASH resolution and fibrosis regression after a year and a half of treatment with the 2.4 milligram weekly dose. So we will need to change again the guideline, and clearly in patients without cirrhosis, with underlying active steatohepatitis, there's a clear indication for resmetirom, and semaglutide has now also the label already in the United States for that. Again, for patients with cirrhosis, I showed you in my previous slides the data on semaglutide in cirrhosis. They didn't hit the endpoints, the surrogate endpoints. So for patients with cirrhosis, we do not have a specific anti-MASH drug pharmacotherapy so far. It doesn't mean, as I said, that some of these drugs might be beneficial. What's the future? Very briefly, there are several pathways that are explored. The PPARs are important. You see here the 3 different PPAR isotypes and their differential expression across a lot of organs. It's important that they are tight regulators of metabolism, but also inflammation and fibrogenesis. I talked about pioglitazone, which is mainly a PPAR gamma, so mainly acting on the adipose tissue and also on the stellate cells. What is probably the most promising compound is the pan-PPAR, so acting on the 3 isotypes, lanifibranor, for which we demonstrated in a phase 2 trial. The phase 3 is ongoing, a clear effect on both NASH resolution and fibrosis regression, but also on the combination of both, which makes sense, because if there is MASH resolution, there should also be fibrosis regression, and fibrosis regression without improvement of MASH is also not very likely. That's why you see the placebo rates, which were also discussed in the previous talk and questioning. You see it drastically drop if you combine those 2 endpoints. Double and triple agonists, tirzepatide, GLP-1 plus GIP. Like with the GLP-1s, there is no direct action of GIP inside the liver, but it reinforces the beneficial effects that we see with the GLP-1s. And what we learned from the phase 2 data, but these were phase 2 data, so again, not phase 3, is a clear dose-dependent effect on MASH resolution. And on fibrosis, there was not a significant effect, and it was also not showing a dose dependency, but most likely there's also an effect on fibrosis. But again, like with the GLP-1s, this is not driven by direct intrahepatic effects. Where there can be direct intrahepatic effects is, of course, in the GLP-1 glucagon dual agonist, because we do have glucagon receptors in the liver with important impact on metabolism and on inflammation. So there is a potential that the dual agonist, by the added intrahepatic effects, might result in a bigger benefit than just the GLP-1 effect. Again, only phase 2 data in patients without cirrhosis with an effect on MASH resolution. And in terms of fibrosis regression, also here you see that there's a difference between placebo and the treatment arms, but no dose dependency, so we will have to wait for the phase 3 data to see what the final results will be. Another pathway is FGF21, and I see I'm always at the end of my time, but I will try to be short. It's produced by hepatocytes mainly, and it's a hepatokine, but it has an impact on the adipose tissue, so it's important to realize again that this is for at least partially working through an improvement in adipose tissue function. Efruxifermin, phase 2 data, fibrosis improvement seems to be clearly there, but again, no dose response relationship, whereas for the MASH resolution, there clearly is a dose response relationship, and we will see what it gives in phase 3. What is important also here is that the combination of MASH resolution and fibrosis regression again drastically drops your placebo rate. Another FGF21 is pegozafermin, a little bit the same picture. You see some numerical effects on fibrosis regression, but not a clear dose dependency, and there is an impact on NASH resolution. Finally, cirrhosis, as I already mentioned, semaglutide, unfortunately not, but what we have seen at the latest EASL meeting was that in terms of patients with cirrhosis, efruxifermin, so the FGF21, did have an effect on fibrosis regression, which in this case means cirrhosis reversal. Again, this is not phase 3, it needs confirmation in phase 3, but this sounds at least very promising. I already mentioned the pan-PPAR lanifibranor. What we showed also was that it impacts not just on steatosis and steatohepatitis, but also on the vascular remodeling and the capillarization, which is an early feature. Of course, it's present pronouncedly in cirrhosis, but in MASLD we see it already early in disease, and it clearly improves with this drug. So probably when you hit the stage of cirrhosis, and where, as we discussed previously, the impact on metabolic drivers is probably not sufficient to induce substantial regression of disease. When you get to the end stages of disease, you need other mechanisms, and there, those that tackle the vasculature, like the PPARs, might be of particular benefit in this category of patients. So in conclusions, the successful treatment of MASH has to take into account the high complexity of this disease. MASH can be an indication for treatments that are not specifically liver targeted, and we have the examples of the GLP-1s. They have liver benefit, and they have also metabolic benefit, cardiovascular benefit, so that's very beneficial for the patients. But we also see now the first successful, really liver-specific, liver-targeted treatments, with resmetirom obviously being the first in class. And I showed you part of a large pipeline of drugs, and we will hopefully see more of that in the future. But specifically for the more advanced patients, we will probably need those specific intrahepatic mechanisms to be successful. And with this, I thank you for your attention.